And our next chapter deals with gastrointestinal bleeding. I'm going to read a vignette, and immediately I'm going to cut out from the vignettes to decision trees, and we're going to have throughout the review of GI bleeding, we're going to be interposing vignettes and decision trees and even pictures to show you. So let me read the first vignette, vignette 28. A 33-year-old man vomits a large amount of bright red blood. Okay, before we go any further, let's look at some statistics, let's look at some hints that help us decide from where is a patient bleeding when they have GI bleeding. So we'll cut away from my face and let's look. Gastrointestinal bleeding. General statistics that are quite useful. 3 out of every 4 patients with GI bleeding, the source of bleeding is from the upper gastrointestinal tract, which is from the tip of the nose to the ligament of Treitz. Very few people bleed from the jejunal ileum, and roughly 1 out of 4, the source is in the lower gastrointestinal tract, namely the colon and rectum. Let's continue. The people who bleed from the lower GI tract, from the colon and rectum, bleed from polyps or cancer or diverticulosis or angiodysplasia or hemorrhoids, all of which are more common in the elderly. So let's think then about GI bleeding as a function of the age of the patient. GI bleeding in young adults, most likely the source is the upper GI tract. GI bleeding in elderly adults, the source is anywhere in the GI tract. They still can bleed from the upper GI, where the statistics are 3 out of 4, but because they are old, they could be the patient that bleeds from the lower GI. But the way the presentation comes also helps you decide what's going on. If the patient is vomiting blood, you don't need any of the statistics that we talked about, because if you are vomiting blood, the source is in the upper GI tract. You cannot be bleeding from hemorrhoids and have the blood swim upstream all the way through your GI tract to end up in your mouth. And so when that is the case, we look at the mouth and the nose and follow with an upper GI endoscopy. So let's cut back to my face again, and we're going to continue now with vignettes. Let me read the same one again. 33-year-old man vomits a large amount of bright red blood. You know the source is in the upper GI. You look at the mouth, you look at the nose, you do an upper GI endoscopy, and you will see the lesion, because you're coming in from above with your endoscope. Then is the lesion, and the blood running out of the lesion is running away from you, down the GI tract, not obscuring your view. So you can make the diagnosis. You can even help stop the bleeding with a laser photocoagulation. Now let's look at vignette 29. A 33-year-old man has had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 20 minutes ago. He's diaphoretic and pale, has a blood pressure on IV over 70, a pulse rate of 110. So we have a young man having actually blood per rectum. We know statistically he most likely is bleeding from the upper GI tract, given his age. And we know he's bleeding right now. He was in the toilet 20 minutes ago. So the answer on this vignette is pretty straightforward. Immediately put a nasogastric tube and aspirate. Because if you recover bright red blood, you know the source indeed was the upper GI. And that's vignette number 30. 33-year-old man has had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 20 minutes ago. He's diaphoretic and pale, has a blood pressure 90 over 70, a pulse rate of 110. A nasogastric tube returns copious amounts of bright red blood. You've defined the source, upper GI. Look at the nose, look at the mouth, and do an upper GI endoscopy. But now when we get to vignette number 31, we got a different situation. A 65-year-old man has had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 20 minutes ago. He's diaphoretic and pale, has a blood pressure of 90/70, a pulse rate of 110. An esogastric tube returns clear green fluid without blood. He's not bleeding from the upper GI because he's bleeding right now. He just came back from the toilet. He's even a little hypotensive. We know he's bleeding as we speak. And yet there was no blood in the stomach or even in the duodenum. That green fluid without blood means you've sampled the duodenum. The green comes from the bile. So now we have a different situation. Let me tell you how we approach this one. Eventually I'm going to repeat all these with decision trees. This is the kind of thing that we will understand better if we go about it several times. So there are 2 ways to proceed here. This man is bleeding right now and is not from the upper GI. Now you might think intuitively, when we knew it was from the upper GI, we did an upper GI endoscopy. Now that we're guessing it's from the lower GI, why don't we do a lower GI endoscopy, a colonoscopy? It typically doesn't work if you have massive bleeding, because now your instrument comes from below the lesion. The blood is coming at you. And all you see with that colonoscope is a Niagara Falls of blood. You don't see the lesion. So that's not practical. There are 2 ways to proceed in this case. A standard answer that if you find in the question is a correct one, is to do a tagged red cell study. This is a study done by the nuclear medicine people. They get blood from the blood bank, they make it radioactive, they inject it into the patient, they scan the patient. If they can see in the scan the blood puddling in the GI tract, they tell us go right ahead and do an arteriogram, which we will do. And if they do not see the blood puddling there, they say, look, don't bother to do an arteriogram, it will not show anything. You're better off waiting. And once the patient is no longer bleeding, you do a colonoscopy. But there is another way to proceed. The problem with the tagged red cell studies, it takes a long time to do it. There are some physicians that are very impatient. They want to decide right away, should they go for the arteriogram or not. And one way to do that, an alternative way to proceed, is to estimate the rate of bleeding. Because when you have a GI bleeder like this, you are not only making diagnostic studies, you're also trying to keep the patient alive, and if you're bleeding massively, you need blood transfusions. Well, if you're needing a lot of blood transfusions, you have a high rate, and we know that if the rate of bleeding exceeds 2 cc's per minute, that you are likely to see that source in an arteriogram. Now, 2 cc's per minute add up to 120 cc's an hour, which means every 4 hours you need a unit of blood to keep your patient alive. So if you have a patient that the description says is bleeding right now, the nasogastric suction is green, clear, no blood in there, and he's required 3 units of blood in the past hour to stay alive, you know he's bleeding at more than 2 cc's per hour, and if you do not encounter the option that says tagged red cell study, which you know is a standard way to proceed, you look for the option that says let's do the arteriogram, because we know that rate of bleeding will be seen. By the same token, we know that if you're bleeding at less than a half a cc per minute, which would take 16 hours before you need a unit of blood, that you're not going to see that on an arteriogram, and you are therefore better off waiting and doing a colonoscopy. And if you're caught in between, then you have no choice but to do the tagged red cell study. But if you find the answer that says tagged red cell study for this particular vignette, it would be the correct answer. Let me proceed with 1 or 2 more vignettes, and then we're going to stop and recap and repeat all this and look at a number of pictures in addition. We're now on vignette number 32. A 72-year-old man had, past tense, had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 2 days ago. He's pale but has normal vital signs. An nasogastric tube returns clear green fluid without blood. Now, this is not terribly significant now, the fact that you recover no blood from the stomach, because he isn't bleeding right now. He bled 2 days ago. We always put the nasogastric tube because it's so easy to do. And if you get lucky and find old blood in the stomach, you know it didn't come from the rectum. You know old blood in the stomach came from the upper GI. But now what we have is a history that he bled 2 days ago. No one would even think of either TAC red cell study or arteriogram. Those things are for patients that are bleeding right now. What you need now is an endoscopy, or 2. If this were a young patient, 30 years old, you would do upper GI endoscopy only, because you know in that age group it's bound to be an upper lesion. But because he's 72, you're going to do both, an upper GI endoscopy and a lower GI endoscopy. Let's repeat all this. Let's now cut away from my face and let's look at a lot of pictures and decision trees. Okay, we were talking about when you know that the source is in the upper GI, after you look at the mouth and nose, you do an upper GI endoscopy. Here is one where you can see esophageal varices as the source of the bleeding. Here is a picture of esophageal varices as they would look on an X-ray. Here is a picture of a duodenal ulcer as it would look on an X-ray. I have to point out, to make sure you don't get confused, that we do not use X-rays in the diagnosis of a patient who's bleeding right now. This is just a reminder of the lesions that you might encounter. And this is diverticular disease that you might see in the older patient, but remember what you do here is a colonoscopy rather than X-rays. And this is diverticular disease again. And this is angiodysplasia, one of the lesions that we pointed out old people may have as the source of bleeding. But let's go back to these decision trees. So the presentation is a bloody bowel movement. Let's first see what is the significance of the color of the blood. If the blood is black, we probably have an upper GI source because that blood is completely digested. This is what we call melena, probably an upper source. If it is bright red, probably a lower source. It hasn't been digested at all. But if it is dark red, it could be from anywhere. Because you could have an upper source where the blood irritates the GI tract, has rapid transit, doesn't get completely digested, or you could have a lower source where the blood sits in the colon and the bacteria begin to digest it. So it goes into dark red. And guess what is the favorite color for people who write questions for the USMLE? They make them dark red blood, because that way they test your knowledge, because it could be from anywhere in the GI tract. All right, let's continue now with thought of management. If the description is a dark red bloody bowel movement, ask yourself right away, is the patient bleeding right now? If he's bleeding right now, put an nasogastric tube and aspirate. If you recover blood, the source is in the upper GI tract, you look at the mouth, you look at the nose, and you follow that with an upper GI endoscopy. Continue with this. Dark red blood bowel movement, you ask yourself, is the patient bleeding right now? The answer is yes. You put the nasogastric tube and aspirate, and what you get now is green fluid without blood. He's bleeding right now, but not from the GI tract and the upper part. You already have ruled that out. Otherwise, there would have been blood in the nasogastric tube. So now the upper GI tract has been ruled out. That's not the source. Dark red blood bowel movement, the patient is bleeding right now. The aspirate is green without blood. There are two ways to proceed, as I pointed out. The standard way, tag red cell study. If the blood is puddling, you do the arteriogram. If not, you wait and do a colonoscopy. But the alternative way is to estimate the rate of bleeding. If it is 2 cc's per minute, which is the same as saying 1 unit of blood every 4 hours, you can do the arteriogram. If it is between 1.5 cc and 2 cc's per minute, you need to do the tag red cell study. And if it is less than a half, you know, which would be 1 unit of blood every 16 hours, you know that you could wait and do the colonoscopy once the bleeding has stopped. Let me remind you again, I said it already. If the option tag red cell study is offered in the patient who's bleeding right now, whose nasogastric suction is green without blood, take it, because it cannot be a wrong answer. This is what a lot of people advocate we do for every patient on the circumstances described. But if the option tag red cell study is not offered, and the patient who's bleeding right now, whose nasogastric suction is green without blood, they want you to estimate the rate of bleeding, like we had already described. Now, if we have direct red bloody bowel movement, the patient is bleeding right now, and the nasogastric suction recovers white fluid without blood, you have ruled out the mouth, the esophagus, and the stomach as the source of the bleeding, but you have not ruled out the duodenum. White fluid means it has no bile in it. You have not sampled the duodenum. So the duodenum is still a possibility. If it is a young patient, do an upper GI endoscopy, because that's probably where it's coming from. If it is an old patient, then do the tag red cell study or estimate the bleeding. Here's a picture of a duodenal ulcer, which could be the culprit in GI bleeding. We typically do not do the diagnosis with barium studies. I have to remind you of that. Now, if you have a history of a dark red bloody bowel movement, but the patient is not bleeding right now, in a young patient, do an upper GI endoscopy, because you know the odds favor the upper source. If it is an elderly patient, you need to do both upper and lower endoscopies. All right, that concludes then this decision tree. We still have 2 more vignettes before we're done with the GI bleeding. Vignette number 33. A 7-year-old boy passes a large bloody bowel movement. In this age group, your best bet is Meckel's diverticulum. And the study you do is radioactively labeled technetium scan. This is not the tag red cell study. We're talking about a study that identifies the gastric mucosa that would be responsible for the bleeding from the Meckel's. And vignette number 34 is another situation where the circumstances lead you in a particular direction. A 41-year-old man has been in the ICU for 2 weeks, being treated for idiopathic hemorrhagic pancreatitis. He has had several percutaneous drainage procedures for pancreatic abscesses, chest tubes for pleural effusions, and bronchoscopies for atelectasis. He has been in and out of septic shock and respiratory failure several times. In other words, a very sick patient. 10 minutes ago, he vomited a large amount of bright red blood, and as you approach him, he vomits again what looks like another pint of blood. This is a stress ulcers. We typically like to prevent these by keeping the pH of the stomach above 4, but it's not easy to do that. Sometimes even with the best of intentions, using H2 blockers and so on, sometimes we still do not succeed in maintaining the pH of the stomach at a preventive level. So once the bleeding happens, we do endoscopy for diagnosis, and then arteriogram for management. Angiographic embolization of the left gastric artery is typically what we do for therapy in these cases.